Hi, I'm Dr. Shazia Jamil from Scripps Clinic and University of California, San Diego. I've been asked to give a talk on management of respiratory failure and coagulopathy. I do not have any conflicts of interest. However, please note that SARS-CoV-2 and COVID-19 is a rapidly evolving field, and therefore, at the time of this recording, this information is current. I wanted to introduce the American Thoracic Society Rapid Response Document team to our audience. We are a group of individuals within the United States and outside who work on emerging lung issues, including viruses, wildfire-associated lung injury, and other aspects. And we were actually working on novel Wuhan coronavirus right in the early January before even the first case got identified in the United States. We were contacting Chinese authorities, scientists, and physicians, and therefore each one of us were actually very much more interested in our clinical practice being pulmonary and critical care physician and had multiple publications throughout this time period. When truly, the COVID-19 became more evident in March of 2020. Each one of us were developing guidelines within our institutions and teaching other physicians. The outline of this presentation is primarily on practical management of two most important causes of mortality in COVID-19 patients. I do assume that attendees already have some basic information about ARDS management and coagulopathy, so I don't have to go through the pathogenesis. However, it's still important to understand that coagulation pathway in sepsis is extremely important. There's a lot of different cascades that happens. It leads to endothelial dysfunction, tissue injury, it leads to thrombosis, and therefore detection of sepsis-induced coagulopathy, also called SIC, and DIC is crucial in understanding COVID-19 disease. We and others have actually seen in autopsy studies a lot of thrombi within the pulmonary vasculature, even when there was no thrombi identified on Doppler ultrasounds, for example. This is a prep in process. Endotheliopathy in COVID-19, there are multiple different mechanisms. Basically, we do believe that ACE2 inhibitors are present on the endothelial wall, and therefore SARS-CoV-2 can easily enter the endothelial wall. It can cause inflammation. We do know that these patients have high von Willebrand factor antigens, high factor VIII activity, and therefore there is a direct endothelial injury that is causing microthrombosis in these patients within the pulmonary vasculature. To summarize, what we know so far is that coagulopathy is associated with high fibrinogen, high D-dimer. However, there's minimal changes in PT, APTT. Even platelet count can be normal or slightly decreased in the earlier stages. We all have heard a lot about IL-6 levels and actually correlates with increasing fibrinogen levels. Coagulopathy is related to severity of illness and death. High D-dimer is associated with increased mortality, and actually worsening D-dimer precedes multi-organ failure. Bleeding manifestations, on the other hand, are not common despite coagulopathy. International Society of Thrombosis and Hemostasis interim guidelines tells us that we should be monitoring these inflammatory markers and coagulation markers, and even if the patient is not in respiratory distress or hypoxic, these patients need to be admitted and followed just because of increased mortality. There are certain questions that come to mind, and I would like to address them. One of the questions is coagulopathy seen in COVID-19 ARDS different than ARDS from other causes? This has been addressed by a study from France in which it shows that even patients who are either fully anticoagulated with prophylaxis or treatment doses of anticoagulation had six-fold increase in pulmonary embolism. Other studies from Netherlands have also have similar findings, so perhaps yes. The incidence of pulmonary embolism in COVID-19 cannot be truly determined at this time, as we're not doing CT angiograms in these patients to decrease risk of exposure. And perhaps it is present in about 20% of the patient, as has been found in several studies. A very nice review I have added in the bottom. Multiple guidelines within the United States and international communities have been developed, but unfortunately there have not been any consensus. There are multiple ongoing NIH trials addressing coagulopathy, therapeutics, and prophylaxis, trying to figure out which is the best agent, but they're ongoing. So at the bedside, what should practitioners do until the results of large ongoing studies become available, until the consensus is reached? We're still admitting patients and taking care of these patients. So what we have done in our institutions and other major academic institutions is that to use the best evidence so far, to sit down with hematologists, pharmacists, intensivists, and develop some consensus and develop best practice guidelines. Also, it's possible you may want to choose one or more professional society guidelines that have so far been published. I've looked at all these guidelines, and for me, I do believe that some of the ISTH guidelines, the ASH guidelines, and Anticoagulation Forum guidelines are very pertinent at bedside management. Therefore, I've included those. The risk stratification for prophylactic anticoagulation, as with any other COVID-19 or non-COVID-19 patients, we must take into consideration extremes of age, extremes of weight, renal function, and drug-drug interaction. Standard prophylaxis could be simple heparin unfractionated 5,000 units 3 times a day, or enoxaparin either once a day based on weight, or 40 milligram once a day, along with sequential compression device, as we have done in other non-COVID cases. However, before we go on to escalation of anticoagulation, we should also understand what is sepsis-induced coagulopathy and what is an SIC score. The SIC score takes into consideration platelet count, the prothrombin time ratio, and a total SOFA. Total SOFA is calculated by respiratory, cardiovascular, hepatic, and renal SOFA scores. And it has been shown again and again that SIC scores of 4 or above actually correlates with mortality. So it is worthwhile to calculate those at the bedside. Intermediate intensity prophylaxis. Why do we want to implement that? Why? Because perhaps failure to respond to prophylactic standard doses of anticoagulation could be due to low antithrombin level or increased fibrinogen. They may be resistant to heparin. Therefore, several guidelines suggest that we should use these interim intensity prophylaxis in patients with critically ill, all patients who are admitted in ICU, or those who have D-dimer greater or equal to 3 times normal, or if their SIC scores are 4 or above. Some of the options you may have is either to do a higher dose of subcutaneous TID of unfractionated heparin, or have a low-intensity heparin infusion that has been used in the past, even in H1N1 acute respiratory distress syndrome patients, or have enoxaparin in different doses as long as creatinine clearance is greater than 30. I must also point out that many institutions are now using a lower creatinine clearance criteria of 15. However, it has to be in conjunction with pharmacists and giving the least possible dose to cause least side effect. Full dose anticoagulation is actually no different. Obviously, patients who already have confirmed DVT or pulmonary embolism, but in COVID-19 patients, we have also seen that lines and dialysis catheters have physical presence of clots. They have to be replaced. Therefore, perhaps those are the patients who should use full dose anticoagulation. If patients have presumed PE and you do not have an option of sending them down for CT angiogram, obviously, those are the patients. And how about those patients who were already on full dose anticoagulation as outpatient and now getting admitted with COVID-19? This is no different than non-COVID-19 patients. Preference of agents comes up all the time, usually either low molecular weight heparin or unfractionated heparin. Where possible, it seems like low molecular weight heparin is a better option in order to avoid additional laboratory monitoring with APTT, have decreased exposure for minimizing phlebotomy. And look at this cutoff criteria that you would not hold anticoagulation unless until the platelets are less than 25 or fibrinogen less than 50. APTT or PT being abnormal is not a contraindication for pharmacological prophylaxis in COVID-19 patients. How about fondaparinux? Well, it may be used in patients who you suspect heparin-induced thrombocytopenia. This question also comes out at the bedside. Should thrombolytics be used? To the best of my knowledge at this time, there's only one case series which showed improvement in oxygenation. There's really no high quality evidence, and systemic thrombolytics should also be used when there is a true indication, as we always do in non-COVID-19 patients. Other treatment modalities, some of us have been doing critical care for a very long time and remember the activated protein C, a drug by the name of Xigris, used in sepsis and septic shock. And there are some recent trials on thrombomodulin and antithrombin. Well, at this time, there are trials undergoing, but we do not have much data. How about monitoring of therapeutic effect of unfractionated heparin? If a patient has an APTT which is normal and you start them on interim prophylaxis or a full dose anticoagulation, you may want to use APTT rather than anti-10A assay. Maybe your hospital doesn't have anti-10A assay, maybe it's a send out. However, in patients who have prolonged APTT, it's better to use an anti-10A assay rather than APTT. Patients, as I mentioned before, may have heparin resistance. In those patients, it's better to use an anti-10A assay rather than APTT. How about low molecular weight heparin therapeutic effect and their monitoring? Actually, multiple guidelines suggest against using anti-10A assay, adjusting low molecular weight heparin, as there is no real standardization or reproducibility, and there's lack of evidence on outcomes for thrombosis. Post-hospital VTE prophylaxis may be on a case-to-case basis in patients who have VTE risk at time of discharge, who were paralyzed and sedated in the ICU. However, those who were never eligible for DOACs should not be on DOACs now, just because they have COVID-19. There are multiple trials ongoing, and if you want to use one of the agents, it should be based on the previous trials. For example, the duration of enoxaparin, 6 to 14 days, or rivaroxaban, 31 to 39 days. So I wanted to provide some guidelines. Let's switch gear to management of respiratory failure due to COVID-19. This is also something of controversy. Based on lung autopsies from us as well as other institutes, many have been published. We are about to publish this. We have seen a lot of different findings. We have seen profound inflammation. We have seen a lot of edema, fibrosis, hyaline membranes, and thrombosis, as I talked about. Mild to moderate respiratory failure can be very challenging, and I think one of the reasons is that most of these modalities require aerosol generating procedures, and there is risk to healthcare workers. There's a pros and cons debate about early intubation versus late intubation in COVID-19. COVID-19 patients have tendency to rapidly deteriorate, so people who would like to do early intubation tells us that perhaps the emergent intubation would be risky to both the patient as well as the healthcare workers. Early intubation may avoid the risk of self-induced lung injury. Maybe the patients would have failed NIV anyway, so why not early intubate? And ability to provide lung protective strategies possible only after intubation. The cons debate, however, tells us that NIV approaches will avoid unnecessary intubation. By doing so, they would avoid ventilator-induced lung injury, healthcare-related pneumonia issues and adverse events. And now we believe that we have sufficient PPE, we can develop negative pressure rooms, so why not wait? The recommendations from international societies and those in the United States, again, are variable, and there is no consensus. So again, what should physician do at the bedside? We already know high-flow nasal cannula is better than nasal cannula oxygen versus non-invasive ventilation from previous studies. There's more and more utilization of non-invasive positive pressure ventilation using ICU ventilators. There are multiple benefits. For example, using an inspiratory and expiratory circuit, patient can be managed by visualization of waveforms. There can be oronasal mask, total face mask, or helmet. But usually if you're using helmet, you have to use a much higher IPAP and EPAP. Helmet has been used successfully in COVID-19 pandemic throughout Europe, which is amazing, and they have published their findings. Just wanted to show you how helmet use look like. And as you can see, patient is awake and patient is not in distress. Obviously, in this picture, there's much more information, and it has been shown to avoid intubation in about 54% of cases as being published. I wanted to do a side-by-side comparison of high-flow nasal cannula and non-invasive positive pressure ventilation. If you're using an IPPV, you must have a negative pressure room. You should have full PPE and N95 for all healthcare worker, while high-flow nasal cannula, if you do not have a negative pressure room, you should have adequate exchanges and HEPA filter. You should have a droplet mask over patient's nose and face in order to decrease the aerosol dispersion. Usually, if you're using high-flow nasal cannula, you also want to give oxygen, but a little bit of PEEP. So it doesn't make sense you start at a low flow rate, and it should be a higher flow rate, such as 50 liters per minute or even 60 liters per minute to start with. Close monitoring is extremely important. There is a new development of a ROX score that was published last year. Usually a ROX score of less than or equal to 3.85 at 12 hours may predict failure. So these are the patients you want to intubate. And this is a formula to calculate at the bedside. In terms of non-invasive positive pressure ventilation, you usually start a CPAP of 10. You want to look at patients' work of breathing and would like to titrate to a more normal physiological respiratory rate. Once again, monitoring is extremely important, including knowing what tidal volumes patients are generating so that they do not cause self-induced lung injury. Let's talk about early prone positioning. Most of these studies came from China and shows that early prone positioning within 10 minutes or even 30 minutes caused improvement in oxygen saturation, decrease in respiratory rate, and even much improved ROX index. We all know about remarkable findings on CT scan if you're able to do so. And then finally, the mortality benefit was also seen in early prone positioning. Prior to COVID-19, there was this eloquent study done of 20 ARDS patients, mostly with influenza or viral pneumonia. And they divided the patient in 4 groups: high-flow nasal cannula, those with early prone positioning, or non-invasive ventilation, along with prone positioning. And what it found was that the high-flow nasal cannula with prone positioning was the most effective compared to other modalities. So we already had this data, and we can apply this now to COVID-19. I'd really like this review article by Dr. Raouf and Dr. Nicholas Hill. It tells us how to manage patients with mild to moderate respiratory failure non-invasively. And the 2 key points actually are presence or absence of respiratory distress and degree of hypoxemia. So these patients may be managed with simple nasal cannula. However, if they are worsening in terms of hypoxemia or developing respiratory distress, they need to be moved to a continuously monitored setting. And then you have the option of high-flow nasal cannula, awake proning, and non-invasive ventilation. This is a tough one. Management of severe respiratory failure requiring intubation. And why is ARDS COVID-19 mortality from China, for example, showed a very high mortality. Even earlier experience of New York showed intubated patient and a very high mortality. So I went back and read many pages of this chapter that we wrote together with Dr. Sprague at UCSD. And really, to my biggest surprise, many things we already addressed at that time apply even today. For example, dry lung strategy, low lung tidal volume, trying to figure out transpulmonary pressure, and the same things apply now. And as you can see, even more than 10 years ago when this chapter was written, we already knew that severe acute respiratory syndrome and pneumonias do cause ARDS. So it is no different now that we know SARS-CoV-2 infection causes ARDS. There has been multiple editorials, debates, and anecdotal points showing or telling us that COVID-19 ARDS could be atypical. However, it is very important to remember that ARDS is not a homogeneous disorder. It has markedly varied presentations. The Berlin definition did not include a respiratory compliance as diagnostic criteria. It's also very difficult to measure in acutely respiratory distress patient who is still not intubated. I really like this article because it's one of the largest CVs, 742 patients with COVID-19 who got intubated. This is from Spain. And they looked at ventilatory management and clinical features of the patients, and they tried to look at other patients who were non-COVID-19 ARDS and try to compare. And what they found was the features of respiratory compliance, the plateau pressure, the driving pressure were similar to other causes of ARDS. In their experience, most patients presented with moderate to severe ARDS. Respiratory drive was high despite adequate sedation. They required a lot of neuromuscular blockade in greater than 70% of the patient. And probability of discharge from ICU was influenced by ARDS severity rather than respiratory compliance. This is another article, although it got published in July 3rd, 2020, but it looked at a previous meta-analysis of ARDS and hypoxic respiratory failure. The authors did a remarkable job. They looked at every single citation that included ARDS and hypoxic respiratory failure. They came up with 15,932. They painstakingly looked at all the studies and finally included 14 studies in this meta-analysis, either with ARDS or hypoxic respiratory failure. And based on their forest plot, it actually shows that if you do a standard management of these patients who are suffering from ARDS and hypoxic respiratory failure, they have improved mortality. Also, it shows that these are the patients who actually develop or are using more low lung tidal volumes. The results were higher ventilator-free days, low lung tidal volumes, and lower mortality in patients who were managed with the standard care. The conclusion of this really great study was that ICUs should consider use of standardized management. And it's the same way that we have done, for example, for pressure ulcers, the catheter-related UTI or sepsis. Why not? We should do the same for ARDS. So what should be the standard management of mechanically ventilated patients diagnosed with COVID-19 ARDS? Low tidal volume reduces mortality in ARDS. We should apply what we already know, that we should apply low tidal volume. We know that plasma IL-6 levels were much lower in these patients compared to others. We should always use a predicted body weight. We know that increased mortality with large tidal volume may be related to cytokine response. We know that COVID-19 have exaggerated cytokine response, so maybe we should be very, very strict in applying low tidal volumes. We already know low plateau pressure and low driving pressure is very important, and we should look into it. We should make every ventilator adjustment to have less than 30 of the plateau pressure and less than 15 of driving pressure. The high PEEP versus low PEEP debate is going on at all times. We do understand that COVID-19 patients, at least some of them may have high compliance, may be highly PEEP dependent, and may not conform to this high or low PEEP ladder. However, at the same time, we know from sub-analysis of alveoli trial that high PEEP improves survival in hyperinflammatory ARDS. It also correlated with IL-6 levels, TNF, and use of pressors. And we now know that COVID-19 ARDS is possibly hyperinflammatory, so why not apply these measures in COVID-19 patients? Another thing that we always talk about is the morphology of lung. If we are able to have a chest X-ray or a CT of the chest, we do believe that focal ARDS benefited from low PEEP and diffuse ARDS from high PEEP. Prone positioning reduces mortality. We already know that, so we should be doing that in every patient with COVID-19 ARDS. Dry lung strategy, we know it is highly applicable to COVID-19 as they're very fluid sensitive and have increased capillary leak. Respiratory drive has been a huge issue in ARDS, whether COVID-19 or not. There's a really nice review article looks into different mechanisms that we all come across at the bedside. I just wanted to point out that perhaps due to a very high inflammatory load and elevated inflammatory markers, a patient have much more respiratory drive and may be difficult to sedate and may require higher neuromuscular blockade. How about veno-venous ECMO? Well, 2019 February in Lancet Respiratory, there was this nice meta-analysis that was published, which showed that in patients with very severe refractory hypoxemic respiratory failure / ARDS, perhaps ECMO should be considered. There are absolute contraindications in COVID-19 patients that have been released now, and we have to be very careful in patient selection. And perhaps veno-venous ECMO should be considered in patients when all other measures have failed after talking to your ECMO steering committee within the institution or regional level. And these are some of the criteria that have not changed, whether COVID-19 or non-COVID-19. We should be monitoring physiological parameters on everyday basis, multiple times a day. All of these that I've listed here, they are not difficult to monitor, and you will do a real benefit to patients when you actually apply your ventilator setting based on these physiological monitors. I have put together this proposed standard ARDS management algorithm that we use at our institution. So knowing what we already know, we would like to apply all this right here. We would like to monitor these patients very accurately. We would like to have a dry lung strategy, prone positioning, which could be when PO2 FiO2 ratio less than 175, but recent reviews have also shown perhaps even less than 200. If the patient has ventilator dysynchrony, we need to go to stepwise fashion and rule out either ventilator sources or patient sources. We should minimize neuromuscular blockade. However, there are patients who actually need a lot of sedation and analgesia and still have ventilator dysynchrony. In those patients, either bolus doses or actual infusion may be required. Inhaled pulmonary vasodilators have never been shown to improve mortality in ARDS. However, they do buy time and may be tried prior to thinking about ECMO. This is a smart phrase that I've created in EPIC that we use multiple times a day in order to look at multiple physiological parameters and what we are doing in order to improve the patient. And this is one patient who was very severe to us, and we had thought about ECMO, and subsequently the same patient actually got better, fortunately, from severe to moderate ARDS and finally mild ARDS, and walked away from the hospital. I wanted to give some guidelines to tracheostomy. This question comes up all the time. Tracheostomy should not be done less than 21 days, as many patients have increased mortality and they may declare themselves within 21 days. We must rule out active COVID-19 infection. We must have a multidisciplinary discussion between different groups that are involved, including the family. And then we decide how you want to do it. Do you want to have a bronchoscopic assisted approach or without? And finally, they should have specific ventilation parameters and paralysis when you're doing so. Thank you for your attention, and I'm looking forward to questions.